Howdy, hello, hi. Aaron Boster here, broadcasting live while on vacation. Had a free moment and wanted to jump online and say hello to this growing global online MS village. Is anybody out there? Testing 1, 2, 3. Hello, howdy, hi. Hey, Mike. Hey, Renee. What's going on, guys? Hey, Poker Vibe. What's going on? Carrie's in the house. Eric's in the house. Cindy's in the house. What's going on, Jason Bell? Great to see you, sir. Monica's in the house. Carrie Perry always in the house. What's going on, lady? Elaine is there. Kelly's there. Dallas representing. UK representing. What's going on? Polly in Missouri. Hey, everybody. Care Bear. Hope you're doing well. Shelly's in the house. What's going on? This is great, guys. I thought I'd take a few minutes and jump online while on my vacay and see how everyone was doing. It doesn't look like the viewer count is posting. Not sure exactly how to fix that, to be honest with you. We might have to go without it today. What's going on, Mike? Hey, how are you? I'm on a cruise right now in the Caribbean, taking a break from clinic for a week. Super excited to be catching some sun, relaxing a little bit, but I missed you guys and wanted to jump on and say hello, howdy, hi. There's enough of you, let's do it to it. You know how we do it? Hey everyone, Aaron Boster here. Great to see everyone. I am taking a week off of clinic on a vacation and really enjoying my time away. It's nice to take a deep breath, kind of regroup myself in many respects. But of course I missed you and I wanted to jump online and say hello, howdy, hi, and see how everyone was doing today. I hope that you're doing well. I'm super excited to be here with you. I thought, what the hey, let's answer some impromptu Ask Me Anything MS questions. It doesn't look like the viewer count is posting, so not exactly sure why we can't see that right now. Many of you know I should not quit my day job as a neurologist. I'm not a videographer or YouTube expert, so we'll have to go without that right now. Let's take a look in the chat. Ryan's in the house. What's going on, man? Thank you very much for the well wishes. Hey, Paige, how are you? 79, what's going on? Some great ports, yeah. We're in the Caribbean, so almost every port is gorgeous. Bonjour, Jennifer. Bienvenue. Merci d'être ici avec moi. Wapakoneta, Ohio is in the house. BC, Canada is in the house. Saudi Arabia is in the house. Almost time for breakfast. I'll tell you, the coffee on this boat is superb. I'm a big fan. Netherlands is representing. New Jersey is in the house. What's going on, guys? Scotland. Hey, Rhonda, great to see you. Thank you for being here. Massachusetts is in the house. Mike, one of our amazing moderators, has jumped online to help out. Thank you. We've got a merchant from India representing. Louisville is representing. You guys are having trouble hearing me? Let me up the audio. Maybe I can get a sound check from everybody. Testing, testing, 1, 2, 3. Mary had a little lamb, over. Is the sound okay? Let's get that sound up. All right, testing. Let me know about the sound. All right, sound any better? Slovakia's in the house. Sound is better. Thank you very much. All right, great. I really appreciate your help. You know, it's funny. Sometimes I collaborate with large organizations that have podcasts and live streams and stuff. And whenever I do that, I'm always amazed because there's a sound guy, there's a light guy, there's a videographer, there's a director, there's a producer, there's all these different people that help, and they're all awesome at their jobs. So when I'm sitting with my laptop, it's just me. So I really appreciate when you guys give me feedback and tell me things like, hey, your sound doesn't work. Romania's in the house. Romania's on my bucket list of place I would love to visit. iPoker says severe pain in the legs, newer symptom. Doc said I look good on the MRI, no thoracic imaging. So iPoker brings up a really good point. Number one, When we do serial imaging, we're oftentimes looking for things that we would miss on exam. So an MRI of the brain is typically very, very helpful because you can see new spots in the absence of new symptoms very commonly on the brain. We don't always image the spine. I typically get a cervical spine MRI about once every couple years, once every 2 to 3 years. I don't do a thoracic spine unless the patient has symptoms localized to the thoracic spine, which would include isolated leg things or sometimes bowel, bladder, bedroom things. And in this case, we didn't get a thoracic spine MRI, they share, and so it's possible there was something there that we missed. I also want to point out that you're not always going to see a one-to-one correlation between I have a new symptom and I have a new spot. It doesn't have to work like that. Very frustrating, but true. That's a great point. I'm sorry to hear that you're in pain, my friend. I hope things are going well. I hear that the sound is still low. Can we get a check? Does the sound better? Testing, 1, 2, 3. Mary had a little lamb. On va faire ça en français. Peut-être ça va être mieux. All right. So, Mike, thank you for helping sort things out. So, Chavez Smart asks a really excellent question. And so we're going to post that question up here. That's working today. Chavez says that Ocrevus isn't available in their country. Is Rituxan good? Yes, Rituxan's very good. So Ocrelizumab, which is the long name for Ocrevus, and Rituximab, or in the United States Rituxan, is in the same class. They're both B-cell depleting medicines. They both work in the same mechanism. They're infused in the vein. They're actually infused in the same schedule, once every 6 months. And what they do is they deplete the B cells. They decrease the number of circulating B cells in the bloodstream. And by decreasing the B cells, it prevents MS from attacking you. It's a pretty interesting mechanism. And they work with the same mechanism. So what happens is when there aren't a lot of autoreactive B cells, those naughty B cells can't piss off the T cells to attack you. And as a result, we see less MS spots on the brain and spinal cord. As a result, we see less attacks and we see less development of new neurological dysfunction. We see less brain volume loss. Now, Rituximab and Ocrevus work by the same mechanism of action, essentially. They're slightly tweaked. So Ocrevus is humanized, whereas Rituxan is not. And that simply means that the makers of Ocrevus have tweaked it so that it's better tolerated in the human body. There's less of a chance of infusion reactions with Ocrevus, but I believe that Rituximab is an outstanding therapy. And when patients don't have access to Ocrevus, I see zero concerns with giving someone Rituximab. And so I think that is a very, very viable option. That was an excellent question. Thank you for asking it. Let's jump in the chat here and see what else is cooking. Michael shares, hello, howdy. I've been having olfactory hallucinations where I constantly smell car exhaust fumes. So that is not typically associated with multiple sclerosis. It's not that you can't have hallucinations, but it's very uncommon in the setting of MS. When I hear about something like that, I think immediately with my neurology brain, could this be a prodrome or an aura for a seizure? Or could this be a prodrome or an aura for a migraine? And so when I hear that, I want you to get ye to the neurologist. And if that was my patient in clinic at the Boster Center for MS, I would order an EEG, where they put the electrodes on your head and they look at the brain waves to see if you're at high risk of having a potential seizure. It's my 2 cents. You definitely want to check that out, and I would ask you to talk to your treating clinician to help you through that. So Monique says, I've been seeing online that folks who take Kesimpta should not take lion's mane. I think that sounds like a bunch of bullshit. I'm not aware personally of any data which would suggest that lion's mane is dangerous for people taking a B-cell depleter. Now, interestingly, lion's mane is a really interesting mushroom. There's gazillions of mushrooms. I mean, I don't know how many mushrooms exist on Earth, but a lot. And there's about 4 functional mushrooms where we think that there may be a medicinal benefit to humans. Things like cordyceps, turkey tail, lion's mane is amongst them. And In traditional Chinese medicine, I'm told that there's a lot of utility of lion's mane for energy and for vitality and for cognition. And I'm aware of one small study done in mild cognitive impairment patients. So this is not the MS population. This is people that have an early concern for possible Alzheimer's dementia. And when they took doses of lion's mane, it seemed to improve their cognitive outcomes. And what I recall from that study was it wasn't a big improvement, and when they stopped, it regressed. And so when they stopped the mushrooms, they didn't do as well. Now, there's no data studying cognition with lion's mane in multiple sclerosis. So that means that I'm not aware of any clinical trials or any studies that have been done specifically looking at the MS population. I'm also not aware of any data suggesting that it would be a problem to do that. Now, all substances you eat can impact the body, and so I wouldn't want to say, oh, there's zero concerns ever, but I'm not aware of any data to suggest that would be a problem whatsoever. So I would always take what I read on the interwebs with a grain of salt. All right. So Chavez says, when would the Boster Foundation take international patients? So the Boster Center for Multiple Sclerosis is located in the Midwestern United States. So that's in Ohio, OHIO. And we see patients from around the globe. We opened a couple days before the onset of the global viral pandemic, the COVID-19 pandemic. And during that time, the telemedicine laws in the United States were kind of liberalized. Literally, the government said, we're not looking. And early on, I was doing telemedicine across all borders. And so I was actually doing some telemedicine with people from other states and people from other countries. And I did that because people needed access to MS neurologists. There was really a terrible situation where people were developing symptoms of MS and they couldn't see clinicians. And so I felt like it was appropriate to do that. As the pandemic started to wind down and those liberalized laws closed back up, it was no longer appropriate, in my opinion, to do strict telemedicine with patients from other places. I do hold multiple state licenses within the United States, which allows me, after I've established care with a patient in my office, to continue to see them in a hybrid, where they come to the office twice a year in person, and I see them on telemedicine as well. However, I don't extend that readily outside the United States. Now, Chavez, if you wanted to come to see us at the Boster Center twice a year in office, we would see anyone from any location. And there are patients that come to visit us from other countries. I'm very blessed that I have patients that come and see us from India. I have patients that come and see us from Dubai. I have patients that come and see us from places in South America and a couple other places in Europe. And so if that's something you're interested in, you can always check out our website. Actually, I'll throw a link to the website in the chat, bosterms.com, yo. So that's our website. I'm very proud of our website. It's a nice website, if I do say so. And you can check that out. There's a link there to become a new patient. And if you can make it to the United States twice a year to see us, we would be very happy to try to discuss that further. All right, so here's a question from Amal, who says, Doctor, my sister, whoops, where'd the question go? Hold on. Has been on Avonex for 15 years. It's no longer available to her. Her doctor gave her a list of alternatives. How can she select? What questions should she be asking? Avonex is a very low efficacy drug. I would submit to you that in the grand scheme of all the different disease-modifying therapies for MS that are currently available, at least in the United States, it is the least effective. Now, that doesn't mean it's the least effective for your sister. If she was on Avonex for 15 years and did outstanding, I'm delighted. And it's always frustrating when you're taking a medicine, particularly one that's working well, and then you don't have it available to you. But my point here is, at least in groups, almost anything else that she would take would be able to beat Avanex's efficacy. Now, your sister's not a groups, she's one individual human, but one of the ways that we try to make decisions about disease-modifying therapies is by comparing data when we look at large clinical trials, looking at how people did on drug A versus drug B. And that's where I'm getting my comment from. So what would I look for when trying to pick an MS disease-modifying therapy? Well, so there's several things that we want. We want a medicine that can be paid for, yeah, because medicine is expensive in some cases, and money doesn't grow on trees, as they say. We want a medicine that is well tolerated. So, for example, your sister was self-injecting an intramuscular injection a couple times a month. There are patients of mine that cannot do that. They can't handle that. They have needle phobia. They're not able to tolerate it. It's exceedingly painful for various reasons. And so I wouldn't assume that's a barrier for your sister, but we have to consider tolerability. There are medicines that are taken orally which make people have all kinds of GI problems, for example, and so that might not be tolerable. So the medicine has to be tolerable. It also has to be safe. Oftentimes, safety is something that we have to check long term as we move forward in time. And so we would look to see, for example, that the liver enzymes in a given medicine didn't spike, or that it didn't suppress the immune system too much. And that's oftentimes something that we're going to sort out as we move forward in time, not at the time that we start the medicine. It is relevant that many of the medicines that we take for MS require monitoring. And so in order to make sure that they're safe, we may need to get laboratories as frequently as every 3 months long term. And so we'd want to make sure that your sister had access to have those kind of laboratories. Also, in my mind, we have to make sure that the medicine is effective. And so what does it mean to be effective? It means that we're not going to have new attacks. We're not going to have new spots on the MRI. We're not going to see worsening of the neurological examination. We're not going to have accelerated rates of brain volume loss. And again, that's something that we determine long term. And so if I was in your sister's position and the doctor said, hey, look, this medicine is no longer available, but here's a list of other medicines, I would do my research. I would look at the different medicines and see which ones appear tolerable and safe and have the highest efficacy, at least in groups of patients. And then that's how I would try to help make my decision. On this YouTube channel, I have many, many videos on how to pick a medicine. I have many videos I've made over the years. I think this channel, gosh, is 10 years old now, where I've talked about the various MS medicines. And so I would offer this YouTube channel as a resource to do some education. It's not the only resource, of course. There's many, many different educational resources that are completely free on the internet where you can up your game and learn about how MS medicines work. And it's my hope that through those maneuvers, your sister can identify her next disease-modifying therapy so she can keep her MS as boring as possible. That was a great question. Thank you for asking it. Let's take a look here. I've got a little water. I'm a little parched. It's hot where I am right now. And you know what that means? It means it's time for the MS Water Challenge, yo. When I drink, you drink. MS Water Challenge. Let's drink up. Whew, that was delicious. All right, let's take a look here. So I'm hearing that people can't hear me very good. Is that still true? All right, maybe I can try to get the mic up a little louder. Testing, testing, 1, 2, 3. Testing, 1, 2, 3. Mary had a little lamb, over. Are you guys able to hear me okay? Someone said a steak a day keeps the doctor away. I'm not sure that's true. Chavez says that we can hear the volume is low. Okay, so I'm getting some no's and some yeses. Honestly, I'm on my laptop here. I'm on a cruise ship. I don't have all my accoutrement. I don't have my fancy dancy microphone that I normally use when I live stream. So I'm sorry for that. Thank you for putting up with me and my technologically challenged self as I try to do this live stream. All right, let's take a look here. All right. Angela, how are you? One of our amazing moderators, Angela's online. Angela, I'm on my vacation. I'm taking a week off from the Boster Center. I'm relaxing on a cruise liner. So Brandon Bieber says, where am I cruising? Dr. Brandon Bieber is a friend of the channel, a friend of mine. He's an amazing MS neurologist, works out in California. Dr. Bieber has an outstanding YouTube channel. So if you guys are not familiar with Dr. Bieber, what are you doing, guys? This guy's amazing. So definitely say hello, howdy, hi to Dr. Bieber in the chat. Send him a little hello. And make sure that you subscribe to his channel. He's got an amazing YouTube presence. He's a wealth of knowledge, and he puts out a YouTube video every week. I look forward to his Wednesday morning videos. He does a really, really great job. So make sure that you subscribe to Dr. Bieber's channel. So Brandon, I'm cruising in the Caribbean. We're at St. Thomas right now. And it's really nice to connect with you, my friend. So here's a great question from Paige La Rosa, who says, is crap gap really a thing? Due from my next infusion in May. So let's talk about this so-called crap gap. So many patients treated for multiple sclerosis use B-cell depletion as their mechanism of treatment. I would submit to you that one of the most common medicines used is ocrelizumab, Ocrevus. There are others like Kesimpta and Briumvi and Rituximab that we talked about a little bit earlier on this live stream. And the minority of patients in my practice, not the majority, but the minority of patients will share with me an experience which has been colloquially deemed crap gap, where about 4 weeks leading up to their next infusion, they feel punky. Sometimes patients feel a little bit more tired. Sometimes patients notice a return of baseline symptoms, where the baseline symptoms sort of seem to be on the rise. And after their infusion, they feel better. And this has been deemed crap gap, and it's really a term which I hear kind of kicked around a lot. Now, the question here is it real? Well, this has been studied a little bit in the scientific literature by some MS neurologists who said, no, it's not real. And the reason they said it's not real, according to them, I think it's real. The reason they think it's not real is because they don't see a change in the immunologic markers that they're looking at. So they don't see that the CD19 count bounces around or starts to return back to normal. But I don't think that hundreds and hundreds and hundreds, if not thousands, of patients that I see are lying to me. I don't think that hundreds and hundreds and hundreds of people that don't know each other all got together and said, hey, let's all tell Dr. B the same fib. Let's tell him that things wear off about a month before our infusion. Deal? Pinky promise? I don't think that's happening. I think that they are experiencing a real phenomenon. I can't fully explain it, but I believe people when they tell me that. And I want to repeat that it's not every single patient that experiences that. In fact, it's not most patients that experience that. I would say that it's the minority of people notice a so-called wearing off, and then after they get their medicine, they feel better. Now, at the Boster Center for MS, when someone shares with us that they're experiencing so-called crap gap, we talk through that. And I've come up with 3 things that we might try to do, or 4 things that we might try to do to make it better. One of those things is we might ignore it. Now, why would I ignore it? We would ignore it because we collectively deem that it's annoying, but it's not interfering with their quality of life. And as a result, we wouldn't want to stop the therapy because there's other good things about the therapy that we think are very valuable. And so in some cases, we'll say, okay, we recognize that it's there, and so we're just going to ignore it. A second option would be to use symptomatic medicines to try to ameliorate those symptoms temporarily. I'll give you an example of fatigue. So sometimes patients will say, a month before my infusion, I feel really tired. And so we will increase their use of, say, a medicine like modafinil or Provigil, or a medicine like Adderall or Ritalin. These are stimulant medicines which can trick the brain into being more awake and trick the brain into being more attentive. And that can help them symptomatically get through that phenomenon. A third thing that we do, and this is off-label, it's not been proven, but it does seem to work, is we might give someone a small exposure to a steroid about a month before their infusion. This can be done intravenously, it can be done orally. We can use a full gram of IV Solumedrol, we could use a half a gram. There's different ways that we try to do this. And what we're trying to do is we're trying to suppress inflammation, we're trying to kind of ease them into their infusion. Again, I want to repeat, most patients do not have this phenomenon, some do. And if it's considered significant enough, and if we weigh the risk benefits of steroids, in some patients we'll give them a little squirt of steroid, a little whiff of steroid, and that can help them quite a bit. There's a couple other things that we do, but I'm going to keep those as company secrets. And that's not something that, fortunately, we have to deal with in most cases with most patients. That's a great question. Thank you for asking it. Let's take another question from the chat. So Chavez says, taking a tapering dose of prednisone, should I continue? Chavez, I can't give you a comment on that. I can't diagnose or treat you on the interwebs. I don't know anything about you or your case. So I definitely want you to talk to your MS provider about that, so that you can get really good information for you for that specific situation. That's definitely something to give a ring to your provider and ask about that. All right, so Crash Test UK is a cool name. Hello, Crash Test UK. Is there anything that you would recommend for non-active PPMS, no inflammation? NHS says no DMT unless there's active. Must be referred to symptom management instead. So the NHS, which is the National Health Service in the UK and Great Britain, uses a socialized form of healthcare where they have rules that they then apply to various patient situations. And so here's an example. Per this question, they're saying, hey, if I've been diagnosed with PPMS and I'm not having active inflammation, well, then I'm not eligible to take a medicine like ocrelizumab. So I immediately have like 28 questions. The first one is, how are they deeming inflammation? So when we do clinical trials looking at primary progressive MS, about a quarter of the patients at entry into the trial have contrast-enhancing lesions on their brain. And we're not imaging the cord in those trials. And so when the nice NHS doctor says that you don't have inflammation, are they doing serial MRIs of your brain and spinal cord? Because if they're not, I question how the hey they're determining that you don't have inflammation. And so if you had an MRI of the brain and cervical and thoracic spinal cord, let's say every 3 to 6 months, which is a lot. I'm not suggesting anyone's going to do that for you, but if they did and they saw no contrast-enhancing lesions, okay. Also, what are they defining as inflammation clinically? Is that only defined by an attack, which to me I think is a little bit odd? Or what about failing the litmus test of life? What about having increasing difficulties in doing something? So I share some frustration with you in that, and I would be looking for evidence of inflammation. I'm not trying to pick a fight with the NHS. I know the NHS includes some very, very smart MS doctors, some who I consider to be friends, but I'm not sure that I completely agree with that. I also think that it's very, very naive to think that a clinician talking to a patient for a few minutes and maybe getting an MRI once a year is adequately equipped to be able to determine whether you're having active inflammation. So I have a major issue with that, if I'm honest. Now, John Scapino is online. He's one of our amazing moderators and a great fella. Pure Michigan, hello, it's great to see you. Even So It As Well is also online. Now, she's a super duper lady who's got a super YouTube channel with some really great videos on her channel. And so if you're not familiar with her, you should be, and go check her out. She throws up a quote from none other than Michael J. Fox, who not only was an actor in the 80s and I think maybe into the 90s, but also has Parkinson's disease. So this message is so simple, yet gets forgotten. The people living with the condition are the experts, Michael J. Fox. And as I am very fond of saying, you are a you expert. So you know more about you than any other human being. You know more about you than my MRI that I get. You know more about you than my MS Olympics neuro testing that I do. You know more about you than I do by asking you a series of 20 questions. And the way I view our partnership, because I think that's what MS neurology really is it's a partnership, is you bring your knowledge of yourself to the table, and I bring all the books I read to the table. And that doesn't make me better than you. On the contrary, it doesn't make me smarter than you. On the contrary, it doesn't make me more knowledgeable than you. It just means that I read some things that you didn't read, which I might be able to use to help you. And then together, we bring your knowledge of you and my knowledge of these books, and then together, we try to game out how we can live our best life despite having MS. So I think it's a really great quote, Even So It As Well. Thank you for sharing that. All right, let's take a look and see what else is cooking. So awesome, Bell Amy writes, if MRI are positive for lesion, is a spinal tap necessary for diagnosing MS? Well, the answer, like many things in medicine, is it completely depends. And so there are a set of diagnostic criteria which have been developed to help aid in diagnosing MS. And so let's spend a few minutes and kind of game that out. But before we do, let's change the scene up. I want to make sure that everybody can still hear me okay. Sometimes I change the scene and then people can't hear me and I feel really bad. So let me know in the chat if you guys are still able to hear me okay. I'm not getting any, I can't hear you, so I'm hopeful that that'll be okay. All right, I'm not getting any comments that people are not able to hear me, so I think that we're doing cool. All right, great. So the question is, if the MRI is positive, do we need a spinal tap? And my answer is, it really depends on what all the diagnostic criteria are teaching us. So if you're talking about the most common form of MS, which is called relapsing multiple sclerosis, we're looking for someone who has at least one event, which sounds like a relapse. So either a transverse myelitis, or a optic neuritis, or a brainstem syndrome. And if they have lesions on the brain and spinal cord, we try to look for lesions in different locations, which we call dissemination in space, and there's 5 locations: spinal cord, base of the brain, which is called the infratentorium, a position called the periventricular white matter, juxtacortical or cortical. Those are the different locations. We also now include the optic nerve, and so there's a new 6th location, and this is from the most recent evolution of the diagnostic criteria. And so we're looking to have at least one spot in 2 of those different locations. So let's say infratentorium and spinal cord, or spinal cord and juxtacortical, okay? And that would meet the so-called criteria for dissemination in space, which is not enough to diagnose someone with MS. We also need to find dissemination in time. Now, how do you do dissemination in time? Well, there's many, many different ways. One way is that you can have a second event, right? So at least 30 days after the first event, you have a second event, and so that's clearly dissemination in time because those things didn't occur at the same time. A second way is you can get a second MRI that shows a new spot. So those were not the same because they didn't occur on the same scan. A third way is that you can have one MRI that has an enhancing lesion and a non-enhancing lesion. So the enhancing lesion is new by definition and the non-enhancing lesion is not new. And so that way you've met the criteria for dissemination in time because those are different times. There's another way, and that's with positive spinal fluid. And positive spinal fluid is defined as having 2 or more unpaired oligoclonal bands. And so, not to be too nerdy, but what you're doing is you're drawing spinal fluid, and then you're drawing blood, and you're looking at the antibodies in both. And so if you have an overproduction of antibodies in the spinal fluid, more than you would expect to see as compared to the blood, then that's considered positive, and that would meet dissemination in time. Now, I would submit to you, awesome Bell Amy, that the majority of patients in my practice don't seem to require a spinal tap. That through the clinical history, their neurological examination, and serial imaging, we don't need to obtain a spinal tap. I would say that probably about 1 in 10 patients I'm working up end up getting a spinal tap. I know that in other places in the world, for example, we were talking about the National Health Service, we were talking about the Great Britain earlier, they tap, I think, almost everybody. And I think they do the same thing in Germany. Now, there's another reason why you might get a spinal tap, and that's to prove it's not something. And so you can look for various other things in the spinal fluid which would make us say, hey, this is not looking like MS. And so, unfortunately, the answer is not straightforward or simple. Awesome, Bell Amy, it's kind of it depends. And Effie says this is very complicated, and it is very, very complicated. MS neurology is not a straightforward field. There's a lot of things that go involved in it. And it's my hope that my YouTube videos and these live streams help educate, empower, and energize, and help simplify these annoyingly complex concepts to help them be more palatable and reachable and digestible to people that are listening. Okay, let's take another question from the chat. Throw your questions in the chat. Let's change up. All right. Maybe this is appropriate because I am cruising right now. I want to make sure that you guys can hear me okay. Mike, thank you for helping out. Enjoy the rest of your day. So R. Higgins has a follow-up question. I really like this question. So R. Higgins writes, are spinal taps used for diagnosis only or part of ongoing MS treatment? So that is a great question. I would say that the vast majority of spinal taps are used for diagnosis, as I just described. And so the last question that was asked talked about whether or not someone needs a spinal tap for diagnosis, and that was a great follow-up question. And most of the time, I would say like 90, 95% of the time, that's the only way that we use a spinal tap is for diagnosis. There are, however, some utility to getting a spinal tap for treatment monitoring and prognosis, and that's by measuring the neurofilament light chain in the spinal fluid. And this is not done routinely in the United States. Again, I've been talking about Great Britain a whole bunch today, not sure why. But I have friends that work at a really rock star MS center called Bart's, which is in London, England. And at Bart's, I've been told that they will do serial spinal taps on some patients to look at their neurofilament light chain. Now, one of the things that's really cool is that we now are able to measure neurofilament light chain in the bloodstream. And so a lot of times that we can do sort of those assessments in the serum and not be required to do spinal taps. There's another unique situation where I, in my clinical practice, will do spinal taps serially in patients that are diagnosed, and that's in the context of clinical trials. So right now, for example, at the Boster Center for MS, we are participating in a phase 2 clinical trial. And so you do different phases of clinical trials. There's preclinical work, typically in non-human primates and in things like mice and whatnot. And then when you think you're onto something, you do a phase 1 trial. And a phase 1 trial is oftentimes done in healthy controls, like I joke poor college kids, where you give them the medicine under observation and see if they explode. And if the drug is deemed to be safe, they'll move on to what's called a phase 2 trial. And a phase 2 trial is really a proof of concept, where you're trying to prove that a biomarker of MS might show benefit. For example, you might show in a very fast 3 or 6 month trial in a phase 2 that it can help the MRI. And oftentimes during a phase 2 trial, and sometimes phase 3, we do other things. We look at various other biomarkers. So I'm involved at the Boster Center for MS in a clinical trial, a phase 2 trial right now, where we're doing spinal taps on patients. Now, not every person in the trial has volunteered to do a spinal tap, I understand, but there's a couple brave souls. These are really dedicated human beings who have volunteered to have a lumbar puncture every 3 months, where we draw fluid, and we're looking at a host of really, really high-end markers for MS. We're looking at genomics, we're looking at their genes, we're looking at various immune factors, we're looking at neurofilament light and the like. And so that's another situation where we might do that. I am super parched, and you know what that means? It means it's the MS Water Challenge time. So when I drink, you drink, you know how it works. Let's do it up. Woo. That's delicious. Love the MS Water Challenge. All right, let's take a look here. LAW made a comment on a previous live stream. LAW was asking about nutrient infusions, and it wiped her out. So I hope that you're doing okay. All right, let's see here. So Melissa Althouse asks about magnesium supplementation. Now, here's the medical disclaimer, right? I can't give you specific advice for you. You have to talk to your provider about what's safe and right for you. Okay, so check. I made my medical disclaimer. So magnesium is something that you can find in foods. And if you do a quick Google search, you'll find that there are fruits and vegetables that have magnesium in it. But oftentimes patients will find a magnesium supplementation in the form of a pill to be helpful. They can find it to be helpful as it relates to spasticity. Magnesium can help with spasticity. Magnesium sometimes can help with constipation, which is unfortunately all too common in the setting of MS. Magnesium can help with insomnia. And so there's a host of reasons why someone might choose to take magnesium. I would say the most common time I see someone using magnesium is when they're having a problem with spasticity. And there's a lot of different kinds of magnesium. So there's magnesium citrate, magnesium glycinate, there's magnesium oxide. I oftentimes, at least as it relates to spasticity, recommend magnesium oxide. When someone's having GI problems, I oftentimes recommend magnesium glycinate and sometimes magnesium citrate. But again, I think the key element here is not the second word, it's the first word. It's the magnesium that can be very, very helpful. And I'll repeat myself, I'm not giving you medical advice. You want to check with your MS provider and make sure that what you're doing is safe for you. So here is a great question from Venetia, and if I said your name wrong, I apologize to you. It's a really pretty name. Venetia D'Souza, who says, what is your opinion with someone diagnosed with radiologically isolated syndrome with positive O bands? So let's unpack that question because that's a real good one. Radiologically isolated syndrome is a diagnosis related to multiple sclerosis when a human being has no neurological symptoms, none. Okay? They don't have a history of progressive decline in function. They don't have a history of attacks. And they don't have any changes on their neuro exam. So when we run them through the MS Olympics and they're doing all the things, we're not finding the trappings of multiple sclerosis on their exam, but the MRI scan looks like MS. So here the person doesn't look like they have MS, but the MRI does. And we call that radiologically isolated syndrome. And this has been studied. I have a friend named Dr. Darren Okuda, who I think is a genius. He's a really, really smart MS neurologist. He's also a really cool guy. He runs a rock star center, one of the best centers in the world, actually, called UT Southwestern out in Texas. And Dr. Okuda, amongst many other investigators, has done a lot of research, but I think Darren's probably done some of the best research looking at radiologically isolated syndrome. At least that's my opinion. And a portion of people with radiologically isolated syndrome are going to go on to have their first attack, clinically isolated syndrome. And the question becomes then, what do we do with those people? And one of the things we do is we don't ignore them. So we want to say, oh, well, that's interesting. Have a good day. We want to do a workup. We want to make sure that we're not missing something. And here's an example where someone has radiologically isolated syndrome. So presumably they have an abnormal MRI, and they've done a lumbar puncture, and they have unpaired oligoglottal bands. So not only does the MRI look like they have MS, but the spinal fluid looks like they have MS. And so what do you do in that situation? I offer treatment to that person. Now, if Dr. Brandon Bieber is still online, he may disagree with me, right? And that doesn't make him wrong and me right. It doesn't make him right and me wrong. It's just a difference of the way that we might approach the situation. But to me, that's starting to build a pattern concerning for possible multiple sclerosis. And I am a very strong believer that the earliest time that I start treating you, the better that we're going to do long term. And so I would actually offer that person some form of treatment. I might offer them minocycline, which is an off-label way of trying to slow down things. I might offer them something like glutaramine acetate, which is a very, very safe medicine. Because I don't want to put them on a big dog drug that's going to create a lot of side effects for fear that they have some untoward effects when I can't even prove they actually have MS. But I would actually consider treatment in that person. If we collectively as a team decided not to start treatment, I would at least want to get serial MRIs in them. And if I saw that they developed new spots, now I really want to treat them. The one thing I wouldn't do was dismiss them. I would want to continue to follow them with serial MRIs and with serial neurological examinations for years and years, so that if we weren't treating them, we could jump on treatment as soon as we were able to confirm a diagnosis. I think what we have seen, not I think, I know what we've seen over my career in MS neurology is that we have become faster and faster and faster to agree that we should start treatment. And this is a patient in whom I would very seriously consider starting treatment. That was a great question, and I appreciate you asking it. All right, guys, I am going to wrap up this impromptu Ask Me Anything chat. Thank you very much for jumping online with me. As always, thank you for learning about MS with me. My name is Aaron Boster, representing the Boster Center for Multiple Sclerosis. I have been doing these live streams about once a month scheduled, and impromptu the way I did just now, going on a little over 5 or 6 years scheduled like this. If you would like to know when I do my scheduled live streams, I want you to sign up for the Boster Corner, which is a monthly newsletter that we put out, which includes all of the scheduled live streams. That way you don't miss them, and you can find them. And I want to thank you guys for watching my videos. I put out a video every other Monday. I used to do it every Monday, and now I do it about every other Monday. I do a scheduled live stream like this once every month, and I jump online like this, just like I did now, when I missed you guys a whole bunch, and I need to connect and say hello, howdy, hi. Thank you for your support, and thank you for your watching of the videos, and thank you for participating, and thank you for your comments. I really appreciate this global, growing online village. It means the world to me. So until my next video or my next live stream, this is Aaron Boster, as always, saying be safe and take care. I'm going to jump back into my vacation. Bye, guys.